Good evening, consultants, fellows on the call, and colleagues. You're welcome to today's presentation on ventricular assist devices. Our presenter is Dr. Charles Okori. Charles, please, your audience.
Okay, good evening, consultants. Good evening, colleagues. I'll be leading today's presentation, and our topic is on assist devices. Oh, my slides are not moving. Let me just slow down. All right, so as a way of introduction, we know that assist devices are used in heart failure. So just a background on heart failure. Heart failure is a common clinical symptom in which results from structural or functional cardiac disorder that impairs the ability of the ventricle to fill or eject with blood. There are many causes of heart failure: disease of the myocardium, pericardium, endocardium, valve disease, blood vessel disease, or even metabolic disorders. Heart failure is categorized according to ejection fraction into reduced ejection fraction, less than or equal to 40%, preserved ejection fraction, more than 50%, mid-range ejection fraction, 41 to 49%. Of course, we also know there is heart failure with improved ejection fraction. Okay, so advanced heart failure occurs when a patient with heart failure experiences severe symptoms that interfere with daily life, despite maximum tolerated evidence-based medical therapy. They have previously been described as having refractory or end-stage heart failure, and they belong to the ACC stage D of heart failure. Okay, so this is the ACC stage A, B, C, and D. A is those at risk. Okay, maybe those who have structural heart disease but without symptoms. B, those who have structural heart disease. A is those at risk of heart failure, okay, but without structural heart disease or without symptoms. B is those who now have structural heart disease without signs or symptoms. Then this includes those who are in NYHA 1 with no prior occurrent symptoms or signs of heart failure. C are those who have prior occurrent symptoms, okay, any NYHA class, including those who are in class 1 who have former symptoms. Then D is the people we are interested in today, those who have refractory heart failure and who require devices or specialized intervention. Okay, so this is the ESC criteria for the definition of advanced heart failure. All the following must be present. And remember that these patients must be on optimal medical therapy. And they will now have all of the following, not just any of the following, all of the following. So they will have severe persistent symptoms of heart failure. So they will be in NYHA 3 or 4. They will have severe cardiac dysfunction defined by any of the following: ejection fraction less than or equal to 30%, isolated right ventricular failure, non-operable or severe valve abnormalities or congenital abnormalities. They will also have, or they may also have persistently high BMP or NT-proBNP, okay, or severe diastolic dysfunction or structural abnormalities. That's if you are dealing with heart failure with preserved ejection fraction, would be severe LVH in hypertrophic cardiomyopathy and others. Okay, then 3, they will also have episodes of pulmonary or systemic congestion. So they will need either high-dose diuretics or diuretic combinations, or they will have episodes of low output requiring inotropes or vasoactive drugs or malignant arrhythmias causing more than one unplanned visit or hospitalization in the last 12 months. 4, they will have severe functional impairment of exercise capacity with inability to exercise or a low 6-minute walk test, okay, or they'll have a peak oxygen saturation, peak VO2, less than 12 ml per kg per minute, or less than 50% of its predicted value, estimated to be of cardiac origin. Yeah. That's their maximum oxygen consumption will be less than 12 mils per kg per minute, or less than 50% of its predicted value. And this will be due to a reason from the heart. Okay, it's always important that guideline medical therapy, guideline-directed heart failure therapy must be optimized before considering additional therapy. Additional therapy will include devices and intervention. The devices will include CRT, ICDs, and all that. But that's not our. We'll still have a lecture on that maybe sometime next week. Okay, so we'll go to mechanical support device, mechanical circulatory support devices. In patients with advanced heart failure who are refractory to optimal medical therapy, long-term mechanical circulatory. You know, in heart failure, there are two major things that are responsible for mortality. Okay, one of them is they usually have progressive pump failure. Okay, so that's what mechanical circulatory devices try to address. Okay, they try to address progressive pump failure. The other one is they are at risk of malignant arrhythmias. Malignant arrhythmias is what the ICDs, okay, electrical activity, that's what they tend to want to address. Okay, so mechanical support devices have been known to reduce the risk of death and also improve the quality of life. Of course, we know that for most of the electrical devices like the ICD, they will reduce the risk of death, but they may not improve the quality of life. Okay, so long-term mechanical support therapy requires frequent follow-up testing, self-care to manage residual heart failure symptoms and safely operate the device, prevent and treat common complications like we see. These are the two types. Our focus today is on ventricular assist devices, but you could have that, or you could also have artificial hearts. So, okay, assist devices in general, when you treat somebody with an assist device, I don't know, I've never seen an assist device before, so I wish I've seen one. So hopefully very soon, be able to see one. Prolong survival and improve quality of life in patients with advanced heart failure. Okay, so that's one of the goals of treatment of patients with assist devices. Then in patients who are eligible for transplant, another goal is to improve or maintain organ function until transplant can be performed. So it's a bridge to transplant. Okay, so the ventricular assist devices are a surgically implanted mechanical circulatory support device that is intended for use outside the home. So they can carry it around, okay, and it wants to support the patients by increasing perfusion and reducing the filling pressures in the heart, okay. It can only assist pumping action of the diseased ventricle, which can fill and contract, but it does so at a reduced cardiac output. The device augments the function. It doesn't actually completely replace the function of the heart, but it helps to augment. So this is the anatomy of the assist devices. Typically, they consist of an inlet cannula. Which is a rigid metal tube, okay, that directs blood from the left ventricle. So there's an inlet cannula somewhere here, directing blood from the left ventricle into an electrical motor, okay, depending on the type, which we'll see. But this now pumps the blood, okay, into the aorta, through a flexible outflow graft. This is like an outflow graft. Okay, so the motor receives power via an insulated cable. The motor will be receiving power. The motor should be somewhere here, receiving power via an insulated cable. Okay, that extends to a tunnel into the skin and is now connected to an external controller connected to batteries. The patient and the caregiver use this controller to receive information about the pump settings, the power consumption, and the battery life. The controller also generates alarm, maybe if the battery is low and any other abnormalities that require the attention of the patient or the caregiver. So we know we've answered this in the MCQs. There are 3 generations of assist devices. The first generation devices, the second generation, and the third generation. The first generation are pulsatile. Okay, so they are pulsatile volume displacement pumps. Examples of the first generation are the HeartMate 1, Novacore and the Thoratec pivot. Okay, so some of the limitations that made that spurred further development is that significant surgical dissection. And these devices are usually very big. Okay, so they were not placed in thoracic cavity, they were usually placed in the abdomen. Okay, and because of that, sometimes you could hear the motor as you are walking around, you hear, so you could hear it and all that, and they usually associate with very high infection rates. So those were the things that made they are obsolete now. They are rarely used, except from what I saw, the Thoratec pivot. That's the only one that may still be in use. The second generation devices are continuous axial flow devices. So second and third generation are continuous flow. And examples include the HeartMate 2, Javik 2000. Okay, so they are more durable, they are smaller, quieter, easier to implant, and they have lower driveline infection rate. They are used more now than, of course. Then now, of course, what is now being used now is the third generation devices. They are also continuous flow, but they are centrifugal. Okay, they are centrifugal pumps. Example include the Heartware and the HeartMate 3. They are durable, more durable than the second generation. They are easier to place, and they have a lower risk of hemolysis or thrombosis. Okay, then they have a lower risk of hemolysis and thrombosis. This lower risk of thrombosis is actually the advantage of this third generation device over the second and the first generation. So their risk of thrombosis is actually very low. Okay, then there are smaller devices now in the testing phase. Okay. No, I think, sorry, this, as at the time of this, it was in the testing phase, but now I think they are now being used more than the second and the first generation. There's also the biventricular assist device. You know, what we have been talking about is the LVAD. That's the left ventricular assist device. But in people who have right ventricular failure, they don't need an LVAD. They will need a BiVAD, which is a biventricular assist device. Example is SynCardia total artificial heart. Then there are studies to show the effect of assist devices. The most important one is the REMAT trial, which used patients with NYHA class 4, okay, with severe LV systolic dysfunction, less than 25% on continuous inotropes. They put assist devices versus conventional therapy. Conventional therapy, of course, will be intravenous or inotropes at home. Okay, so it was discovered that this pulsatile, that's the one, this remark trial was done then. So the first generation devices were superior to medical therapy. Although the patients didn't live long after, but they would have died anyway from progressive pump failure. But 23% of them were alive after 2 years. Okay, so they still had high mortality. Okay, but it was far superior to medical therapy. Okay, so then this now led to continuous improvement that provided the HeartMate 3, which is an intrathoracic magnetically levitated centrifugal continuous flow pump that has wide flow paths and intrinsic pulsatility. Then the Momentum 3 trial compared HeartMate 3, that's axial flow versus centrifugal flow, and found out that there were lower rates of stroke and GI bleeding with the HeartMate 3. Okay, so that's why that is now the ideal LV assist device. So what are the indications for LVAD? LVAD can serve as a bridge to heart transplantation. It can serve as a destination therapy too in people who transplant is contraindicated. It can serve as a bridge to decision in people with emergency LV function, people with how will I put it now, sudden LV dysfunction. Okay, where a decision, they want to know whether the LV will recover. So it can be a bridge to decision. And of course, if the patient recovers, it becomes a bridge to recovery. So it's important for us to remember bridge to transplant destination, bridge to decision, and bridge to the recovery. So the indications include NYHA class 4 for 60 to 90 days, maximal tolerated medical therapy, okay, with certified respiratory therapy or with an ICD if indicated. Chronic dependence on inotropes, EF 25% less than, wedge pressure more than 20, of course, systolic blood pressure less than or equal to 80 to 90, cardiac index less than 2 liter per minute per meter squared, with evidence of hypoperfusion, declining renal function or right ventricular function. Okay, this is from the ESC guideline. This is from the This is from the ESC guideline that summarizes the indications like we've talked about. Patients with severe symptoms despite optimal medical and device therapy. So if a device therapy is indicated, like if a CRT is indicated, a CRT will come before an LVAD. Okay, without severe right ventricular dysfunction and or severe TI, with a stable psychosocial background, okay, because they have to be compliant to your treatment, attend regular checkups and all that, and be able to tackle the complications that may arise, and the absence of major contraindications. Okay, and they now have one of the following: EF less than 25%, okay, peak VO2 less than 12 or less than 50%, which we have said, more than 3 heart failure hospitalizations in 12 months. This is what the ESC guideline says now. Then dependence on inotropes or a temporary mechanical cardiac support device. Then progressive end organ dysfunction, type 2 pulmonary hypertension, cardiac cachexia due to reduced perfusion and not due to inadequately low filling pressure. That's a wedge pressure of more than 20, BP of less than or equal to 90, and cardiac index. Let's take note of the cardiac index, less than 2 liter per minute per meter squared. So what are the contraindications? Right ventricular dysfunction. Okay, so either primary or secondary. Okay, okay. So, okay, sorry, it's either primarily right ventricular dysfunction, okay, not secondary to left heart failure. This is because improper function of the right ventricle will lead to insufficient filling of the left heart, which may lead to inadequate inflow in the device, and ultimately the device will malfunction. So you need to be sure that the RV function is optimal. Okay, then acute cardiogenic shock with a neurological compromise. If there's a neurological compromise, a contraindication. Coexisting severe terminal comorbidity such as severe renal, pulmonary, or liver or neurological disease or evidence of advanced metastatic cancer. They are also considered contraindications. Of course, these patients will be on anticoagulation. So any active bleeding, thrombocytopenia, platelet count less than 50,000, confirmed heat, heparin-induced thrombocytopenia makes this also a contraindication. If the patient can't be on anticoagulation for any reason, it's also a contraindication. Anatomical factors like hypertrophic cardiomyopathy, things that make it anatomically difficult or less feasible to place the device. They are a hindrance to device placement, so they serve as contraindications. Technical limitations, if you have people with small body surface area, okay, is also then social considerations like psychiatric illness, inability to comply with checkups and maintenance, lack of family or psychosocial support. All these things could also pose contraindications in selected patients. So this is how the LVAD looks. This is how it looks when placed. This is a more detailed picture of the third HeartMate 3 generation LVADs. This is the LV. This is the LV. Okay, so this is where the pump is. So blood enters there, and the blood is driven outwards, spinned centrifugal, then driven outwards like this. There's a cannula here in the aorta. Okay, so this pump is considered to be a continuous flow pump because blood flow is continuous. okay, and not interrupted. Okay. Although this pump has rapid changes in rotor speed that will create an intrinsic artificial pulse. This is the three. This is what the two doesn't have. So this is a detailed picture of how it looks inside. From the LV, this is the inflow cannula, enters the motor. From there it is pumped. This is the cannula that eventually comes out here to the aorta. So long-term management of patients with LVAD consists of follow-up to look for complications and heart failure symptoms, maintenance of anticoagulation, lifelong anticoagulation and antiplatelet, self-care, battery management, education, of course, so that they can maintain it well, wound maintenance, optimal treatment of chronic conditions, CKD, lung disease, depression, all of them. Then, of course, appropriate assessment, for heart transplantation. What are the complications of assist devices? Hematological complications will include bleeding, which is the most common. There are many reasons why they will bleed. Of course, they are on anticoagulation with warfarin. There's also impairment of the normal clotting mechanism. Some of them will have acquired von Willebrand's disease. And there's a leak at the pump site from polyester grafts. Okay. In the conduits, okay, in the mucosal surfaces of the GIT and the intracranial vessels. The INR for warfarin here is 1.5 to 2.5. Apart from bleeding, they may also develop thrombosis, pump thrombosis, embolic events, stroke. Stroke is actually a common complication and increases the risk of death. Hemolysis, technical complications may also lead to lysing of blood as the cells go through the motor. Some of them may be lysed. Okay, then many other reasons for hemolysis, if the cannula is not well positioned, or if the person has heparin-induced thrombocytopenia, if it's on heparin. Other complications include right heart failure. Okay. With the pressure taking off the LV, the septum shifts to the left. Okay, so this will now lead to an increased venous return to the right ventricle. And if patients who are not able to tolerate it, or patients with pre-existing pulmonary hypertension, it can lead to right heart failure. Then infection is also a very important complication. Infection can occur at the pump site, pump pocket, or the drive line. They typically present with signs of infection, warmth, erythema, fever, leukocytosis. Commonly, of course, will be Staph aureus. Then others, Enterococcus and other Staph species. Gram-negative likely is going to be Pseudomonas aeruginosa. So it's good to be aggressive with antibiotics. Sometimes you may need to bring out the device, the drive line away from the infection site. So most times you need to replace the pump and use ECMO in the meantime, or cardiac transplantation as definitive treatment. Other complications, neurological, we talked about stroke, can cause ischemic or hemorrhagic stroke. Okay, if there's partial obstruction of the inflow cannula, or deformation of blood in the pump apparatus, okay, or if there is subtherapeutic anticoagulation, then a risk of hemorrhagic stroke is due to anticoagulation. So there's a fine balance between anticoagulation, between thrombosis and bleeding. Other complications include arrhythmias. Ventricular arrhythmias are very common. Of course, you are touching the LV myocardium, so you may damage it, leading to formation of re-entry circuits. This can trigger an arrhythmia. Medical treatment is usually unsuccessful. Refractory cases may require ablation or exchange, removing the device. Other complications, aortic valve insufficiency. The LVADs tend to alter blood flow dynamics. They increase stress on the aortic valve and the aortic wall, so they can cause progressive degeneration. And people who have aortic insufficiency already, it may worsen the insufficiency. So that's also an important contraindication. Then abdominal complications in the first generation LVADs, they are usually implanted in the abdomen, so they can cause GI obstruction, fistula adhesions, although these are not seen with the modern devices. So I'm done actually. Just a quick note on artificial hearts. It's a surgically implanted device used to treat refractory heart failure, not amenable to treatment with an assist device. So it increases cardiac output and reduces filling pressure. In contrast to an LVAD, it completely replaces the function of the native heart, unlike the LVAD. So both ventricles and most of the atria are excised. Okay, they are not frequently used. They consist of two rigid ventricles. It's just the same, but it's just like creating a conduit artificially. Okay, where blood is received and blood is pumped out. This is how an artificial heart looks like. Conclusion: approach to management of advanced heart failure includes measurements such as optimizing evidence-based therapy, sodium management and monitoring, optimize GDMT devices, and of course, like we discussed, LVAD is used to treat advanced heart failure, either bridge to transplantation, bridge to recovery as destination therapy in patients who are not eligible for transplant. I picked out two questions from Brunwald on assist devices. So this is the first one. Maybe I don't know whether I should go through it or
Please go through it or go through, I beg.
Okay. Okay. A 72-year, I'm trying to remove this thing from my screen. It's blocking the question. Okay. A 72-year-old diabetic man with long-standing dilated cardiomyopathy presents for evaluation of dyspnea at rest. He has been hospitalized 3 times within the past year for decompensated heart failure and recently underwent cardiopulmonary exercise testing that measured a peak oxygen consumption of 10 mils per kg per minute during maximum effort. His past medical history is notable for replacement of an ICD as well as prostatectomy 1 year earlier for adenocarcinoma. For the past 6 months, he has been intolerant of beta blockers because of hypertension. He has a supportive family, adheres to therapeutic recommendations, and does not use tobacco. Physical examination reveals a blood pressure of 92/78 and heart rate of 106 beats per minute, BMI of 26, JVP of 10, clear lungs, S3 gallop, and cool extremities, but there's no evidence of hepatomegaly or ascites. Lab studies are notable for the following: sodium is 126, potassium is 4.6, urea 34 milligram per day, creatinine is 2.5. Liver function test and complete blood counts are normal. ECG shows sinus tachycardia with a QRS complex duration of 96 milligrams per dl. Echo shows dilated left ventricle with an ejection fraction of 20, mild MR, and a normal RV size and function. Which of the following is the most appropriate consideration for this patient? I don't know who can answer. Somebody should just. Anybody? All right.
Implantation of a left ventricular assist device.
Okay, yes, that's actually the correct answer. The patient will not require a CRT because it doesn't qualify based on the. Sorry, Dr. Amina, you want to? Are you saying something?
Yes. I thought you said somebody should answer.
Go ahead. Go ahead. I heard your answer.
The patient will not require CRT because the QRS complex is just 96. Hello?
Okay, yes. Okay. Yes, the patient, like you said, the patient won't
Isn't
require.
it, Dr. Okoye?
Yes, you're correct.
I'm attempting the question.
Yes, you're correct. Go ahead.
Okay. Then urgent listing for cardiac transplantation. I don't think there is need for urgency here. And I don't know. Probably he will need the LVAD before the cardiac transplantation as a bridge to destination or bridge to transplantation, sorry. I don't know if he has any contraindication to cardiac transplant based on these findings. They said he doesn't smoke tobacco. Okay. Implantation of LVAD, that's the answer. Implantation of biventricular assist device, there's no need for that. The patient doesn't have right ventricular failure or right ventricular dysfunction. It's just the left ventricle. So no need for biventricular assist device. The answer is D.
Yeah. Thank you so much, Dr. Mina. It's as you said, the answer is D. The patient will not.
I want to find out that JVP is not raised.
It's raised. Yes.
10 centimeter of water.
Okay, it's raised. So, okay.
Why the patient will not require transplant? They said he had adenocarcinoma.
Okay.
So because of that, he won't qualify for a transplant.
Okay. Thank you.
So apart from that, I think all the things you've said them all. All right. The next question. Okay, so this is 333 in one word. The circulatory support device seen in the radiograph in figure 3.3 has been shown to significantly improve survival and quality of life in select patients. Common adverse effects associated with this therapy include all the following except. So who can please attempt? Okay, so for this one, the correct answer is actually C, because according to this is a third generation assist device. This is a third generation assist device. So don't ask me how they knew. I actually don't know how they knew. But third generation assist devices are associated with are the ones associated with least thrombosis. That's why, like I said, that's why the answer is C.
Dr. Okore, please, how does it cause right ventricular failure?
Part of the contraindications for assist devices is anybody that has any right ventricular failure. Okay, because it will actually worsen right ventricular failure. The left ventricle is now functioning better. More blood now comes to the right part of the heart. So if the right ventricle is not able to stretch and comply, okay, it will actually either worsen right ventricular failure or in people who are predisposed, or people who have pulmonary hypertension, will cause right ventricular failure.
Okay.
That's why you don't mix a good battery, a strong battery, and a weak battery.
Weak battery. Dr. Gunda.
So, thank you. Thank you.
Both of them.
Thank you very much, Charles. Thank you for the presentation. We are grateful. But with respect to how it causes the right ventricular failure, from your explanation, I thought you mentioned that it unloads the left, and therefore there's the bulging of the septum because the RV becomes more compliant, and that increased volume load on the right predisposes it to right ventricular failure, compared to if the person had a pre-existing right ventricular failure, right ventricular dysfunction. So I thought from the explanation, even if you have normal right ventricular function, having an LVAD is a risk factor for right heart failure from the explanation you gave.
Yes, it is. It is. It is.
Thank you very much. So at this point, we'll call for contributions from our colleagues on the call, and we'll go to our consultants and fellows on the call for any additions and guidance. kindly unmute and ask your questions. Amina, go ahead.
Okay, thank you very much, Dr. Okore, for this wonderful presentation. My question is regarding the one of the complications which you mentioned, aortic insufficiency. I was a bit confused how this will lead to aortic insufficiency, seeing as it unloads, like just what Dr. Eugene said, it unloads the LV. So how does it? Because based on my understanding, it kind of bypasses the aortic valves, isn't it? Just maybe better explanation. Thank you very much.
Thank you so much. Yeah, there are many reasons actually for why it will cause aortic insufficiency. One of them, trying to move to this. Okay, just a minute. Okay. Okay. It actually, like in that image, the cannula actually bypasses the aortic valve and it's now put at the aorta. So it means that the aortic valve is not the normal blood that will pass through opening and closing is not there, and that blood too may also be able to leak back. Okay, so patients with LVAD may actually experience worse. For those who have regurgitation, it may actually become worse after placement of LVADs. And that reason is also that with implantation of LVAD, there can be increased pressure or increased flow in the aorta. There's more increased pressure and flow in the aorta, and this will also stress the aortic valve more and also contribute more to aortic insufficiency.
Good evening. So if I can also come in a bit. So you remember that the native aortic valve is still intact and there's still some function, opening and closing of the aortic valve. So, and you also remember that this is more of a continuous flow. So the gradients within the aorta will be of a certain pressure. So that also affects the opening and closing of the aortic valve. So that tends to also cause sclerosis, and that is what leads to the degeneration and the commissural fusion that you would see. And because it offloads the left ventricle and feeds the ascending aorta directly, the pressures there can also worsen the aortic insufficiency. So it becomes more progressive. Thank you.
Thank you.
Thank you very much.
Thanks for the presentation. Please, there's no role for NOAC in anticoagulating this patient, because I only saw you mention vitamin K antagonist as a drug for the anticoagulation in this patient.
I did not actually see role for NOACs. All I saw was warfarin and heparin. So I didn't see any role for the newer anticoagulants in the anticoagulation of these patients.
Okay, sir.
Any other questions, contributions? You know, usually when it comes to those mechanical devices, as much as possible, if you notice, there's little data for the use of the NWACs. And most people are also, it's a matter of sometimes getting ethical approval, you know, for such studies, because they are very high risk procedures, and to get them thrombosed, but testing new drugs can be very challenging. So, but I believe with time, it's possible we may have NOACs being used in some of these valves. Like as of now, we still don't use NOACs for mechanical valves. So probably it's the same reason why indirectly. We are not using wax for this LVADs. But Charles, what's your comment on the RVAD? Like, what devices are available?
Well,
And how do they
well,
work? Are they the same principle or they have different principles underpinning how they function?
well, what I actually saw was a BIVAD. That's patients who have LV dysfunction and RV dysfunction. Okay, they don't need a left ventricle. They need both ventricles to be supported. Okay, but there is also a place for RVAD. That's isolated right ventricular assist devices. Yes, there is a place for that, but I didn't really I don't have much information on it actually, so I didn't really. But I believe it should be the same principle. It should be the same way the LV assist device functions. Thinking about it, it should be the same way they function. Blood bypassing the ventricle and pumping it now instead of into the aorta, into the pulmonary artery. That's what I think.
All right, thank you very much. Okay, so I think Dr. Joe is on. Hello, sir. Good evening. Dr. Joe, please, any contribution, pointers, guidance?
Good evening, Dr. Egan. Am I audible?
Yes, please.
Yes, I want to appreciate Dr. Okuri for the presentation. I just want him to tell us, just explain that introductory slides. What's the difference between refractory and advanced heart failure? Am I audible?
Yes, please.
Hello, sir. Yes, we heard your question. You said what's the difference between refractory and advanced heart failure? Okay, so advanced heart failure is patients who experience persistent symptoms that interfere with their daily life and they are on maximum tolerated evidence-based medical therapy. These are the patients that will require devices. Okay, so they will require either an ICD or depending on the clinical picture, CRT or an assist device. Those are the patients that have advanced heart failure, and they have biochemical parameters that define them. Okay, they have things like they have a peak maximal oxygen capacity of less than 12. They have severe LV systolic dysfunction. They are inotrope dependent. Which other one? So those are the things that define them. So I think it's actually the same thing, advanced heart failure, refractory heart failure. I'm not sure if there's any difference between the two of them, because these are the things that define those patients. And those are the patients that will be referred to an advanced heart failure clinic, and they will now be evaluated for further for either devices or transplants, because if they are put on a device and still symptoms are still persistent, because they will be in NYHA class 3 or 4, and they are the ones that will finally be put on the transplant list and eventually get a transplant. So I think advanced heart failure, refractory heart failure, they are all the same thing. End stage heart failure, they are all the same thing.
Okay, I actually asked because maybe by the time you start doing orals now, you see a question like this, which you have to differentiate. And the question will look like, when does advanced heart failure becomes refractory? Now, the difference, they are not the same. They are not the same. So when you say advanced heart failure, you've already given us the criteria for defining advanced heart failure. Now, when a patient is having heart failure and put on optimal guideline-directed medical treatment, and they are still having all those criteria that you have listed, is advanced. And these are the patients that you will now consider not only devices, you may need now to now consider them for surgery, for those one that has indication for surgery. You may now need to also consider some of them for revascularization, for those one that possibly have ischemic cardiomyopathy and you have done your investigations and your tests have shown you that maybe there's still some hope for after revascularization. So it is when you have done all of this, you have done surgeries, you have done revascularization, you have put on devices, either CRT, ICD, and patient is still not responding, or patient is still in heart failure. Despite all of this, your non-medical or device-based or surgical-based or revascularization therapy that you have done, that the heart failure now becomes the fact. And at that stage, that there's no other thing to do than to go towards transplant. So when they have that, you should discuss my patient with refractory heart failure. What you are discussing at that time is not device again. It is now transplant. So you now want to put this patient, lead this patient for transplant and look at the indication and the contraindication for transplant in that patient. So it is now that is time you now talk about your left ventricular assist devices as a bridge, as you have said, either to transplant or destination therapy for patients that cannot, you can't do transplant for, maybe because of the contraindication to transplant. So that's majorly the difference. So refractory like the end stage, just the end of all your possible efforts, your possible treatment, your possible devices, your possible revascularization, and patient is still in heart failure. And the only treatment for a patient that has refractory heart failure is transplant. I don't know if I'm audible.
Yes, Chief, we heard you, sir. Thank you.
Yeah. All right. So that's the difference. Thank you.
Thank you very much. Any other contributions or questions? In the absence of that, let's show our appreciation to Dr. Corey. Thank you very much for doing this presentation. We are grateful. So we'll move to the next part of the day, which is solving the MCQs that we'll put on the page. So I'll go off briefly just to start the conversion and I'll join again.